welcome to another episode of Fresh Natural Live. We're coming to you a little bit earlier than usual. I have some conflicts for later today, so I planned the show earlier. So hopefully many of you did get the notice. We're going to be talking to you about a condition known as atrial fibrillation. Many of you may have heard of this condition. You may have had loved ones diagnosed with it. And it's one of the most common heart rhythm problems we deal with in cardiology and cardiac electrophysiology. And I think it's important for you to understand some basic facts. So this is going to be a very important and informative show. So sit back and relax. Welcome back to the show. So we're going to have a brief little discussion on this topic known as atrial fibrillation. What I'm going to do is I'm going to review a review article that was published in the New England Journal last year, actually. And it's actually a pretty thorough review on the topic. They have a case presentation, so I'll go through the article and talk to you about the basics of atrial fibrillation, define what it is, and help you understand how it might impact your health. And then at the end, I'll give you my approach to patients with this health condition. So atrial fibrillation is a common heart rhythm disorder. So the New England Journal article starts with this case presentation of a 63-year-old lady who, 60-year-old man who comes in otherwise healthy, was discovered to have atrial fibrillation during an evaluation. He had suffered a viral respiratory infection, and this is one of the common ways in which people present with atrial fibrillation. He reported 3 months earlier he began to notice some occasional dyspnea, that's just medical jargon for shortness of breath, while climbing stairs. And whenever someone has exertional symptoms, exertional shortness of breath, or exertional chest discomfort, we tend to think of a cardiac cause, whether it's due to coronary disease or heart failure. But when you have to increase your effort and when you have to exert yourself, climb stairs, run, and get up and do things, that requires more cardiac effort. So when there's some kind of exertional symptom of shortness of breath or dyspnea, we think of a cardiac etiology. It doesn't mean it is all the time. You know, sometimes people with some pulmonary condition can have exertional dyspnea. But they'll also have dyspnea that's spontaneous or sporadic, as you can with cardiac disease. So on physical exam, he had a BMI of about 29, blood pressure 142/88, so a little on the borderline high side. Heart rate was 120 beats per minute, which is fast, and it was irregular. And the EKG showed classic atrial fibrillation, with an EKG tracing rate of 110 beats per minute. And so then they pose the question, how would you evaluate and treat this patient? So we start off with a patient that presents with atrial fibrillation. You have a clinical scenario, and it's a typical case presentation. I remember we get this when I was in training. Someone would present a case, and they said, well, Montgomery, what would you do? And, depending on what your level of training is and how much knowledge you have, how confident your response is. But typically we want to start off with a discussion of the condition. And so that's what they do in the article. What is atrial fibrillation? Well, it's the most common sustained arrhythmia encountered in adults. As found to be 37% among population over the age of 55 in the Framingham study. Risk factors include older age, coronary artery disease, male sex, European ancestry, hypertension, obesity, smoking, etc. So as you can see, a lot of conditions, diabetes, obstructive sleep apnea, family history of atrial fibrillation, that's one, but there are a lot of metabolic conditions that are there too. So that gives you a clue that atrial fibrillation, at the very least, is associated with chronic conditions that either contribute to or also due to underlying metabolic disease. And I think that's an important thing to to make note of. There's a large multi-institutional study showed 19% of the patient with newly diagnosed atrial fibrillation had an acute precipitant such as pneumonia or surgery. So pneumonia, surgery were the most common cause, but they can also happen associated with heart attacks, as they're called myocardial infarctions, or blood clots to the lung, pulmonary embolism. So there are a number of things that can be associated with atrial fibrillation, but among them are the things that are thought to be the most common is surgery, and I've seen lots of patients with postoperative or also viral pneumonia-induced atrial fibrillation. Alcohol intoxication is one thing that is also associated with atrial fibrillation. There's a condition known as holiday heart syndrome. And so with holiday heart syndrome, you can have atrial fibrillation. Alcohol can be a direct irritant to the heart. So it's not uncommon that you can see that. So there's the issue with atrial fibrillation. I'm just going to break it down. This goes through it in some detail, but the main issue with atrial fibrillation is an abnormal rate. So someone's in atrial fibrillation, usually the heart rate's elevated. So an elevated heart rate can cause weakening of the heart. So not only the irregularity and inefficient pumping of the heart because the atrium is fibrillating and not contracting in a synchronized manner, but it's also fibrillating and also the heart's beating faster. So that can, over time, lead to weakening of the heart. So that can progress to the point where you're in heart failure, congestive heart failure. So atrial fibrillation predisposed to that. Clean V 2013, good afternoon. How are you doing? Norma Aldane, how are you doing? Good afternoon. Thanks for joining us today in this early session of Fresh Natural Live. The other issue with atrial fibrillation, which is probably the real concern that we all have, is the risk for stroke. So people with atrial fibrillation, and the theory is that the atrium is not contracting effectively, so it's fibrillating, so you can build up with inefficient flow or turbulent flow, and so blood slushes around, particularly in the left atrial appendage, and it can predispose to clot formation and embolization of the clot, where it can cause a stroke. So stroke is really one of the major concerns with atrial fibrillation. Of course, heart failure is too, but it takes a while for heart failure to develop. And in some people, it may take a while for the stroke to occur. I've seen patients with atrial fibrillation for a long time, and they have a stroke maybe after 2 or 3 years or 5 years or whatever the case may be. But stroke is one of the things that we really struggle over in terms of trying to prevent. So the risk of death is increased with people with atrial fibrillation about almost 2.5 times in men, about 3.5 times in women. So in summary, some of the key clinical points: atrial fibrillation associated with underlying heart disease with increased risk of death, stroke, heart failure, and dementia. Again, dementia is associated with the fact that you're having lots of blood clots going to the brain and impairing brain function. So you can have a lot of subclinical strokes. Some people have clinical strokes where they have a sudden onset of numbness or weakness or loss of speech. But then some people have subclinical strokes where you get, blood clots to the brain. And so you're having brain anoxia, and over a period of time, you forget where you put your keys, or don't remember your, address or things like that. So that can lead to dementia. Therapeutic conditions associated with it: you want to control the hypertension, sleep apnea, diabetes, hyperlipidemia, stop drinking. Those are things. So again, we're back to the lifestyle things that we talk about frequently with other disease conditions, health conditions. The presence and absence of risk factors for stroke is used to estimate the risk of stroke. So we have a scoring system, and I'm going to go over that with you later in this talk, where the more of these chronic illnesses you have in the setting of atrial fibrillation, the higher the risk of your stroke. So if you can control these chronic conditions, you decrease your chance of stroke. And then some patients will ask about, hey, can I come off a blood thinner if, I control these other conditions? And we're going to talk about that a little bit later when I share, my input to a patient regarding a patient I have taken care of. And there's some other clinical management things. It's not so relevant to the general public. The presence of atrial fibrillation 48 hours or longer. You should try to cardiovert after you anticoagulate. If somebody goes in atrial fibrillation for the first time, it's been in less than 40 hours, you can cardiovert immediately Most of the time, you don't know that, so we tend to anticoagulate first, and then we cardiovert. Again, if you cardiovert somebody, and cardiovert means to shock the heart, get them from atrial fibrillation to a normal rhythm. If you do that, that's thought to be predisposed, thought to be associated with increased risk of stroke. So uncontrolled tachycardia can lead to deterioration of left ventricular function, as I said before, or heart failure. So you want to try to get the atrial fibrillation under control as soon as you can, because it's going to lead to more atrial fibrillation. So next, we're going to talk about some mechanism. But before we get into that, I want you to pause and give us a thumbs up or share if you hadn't had a chance to share this video. I think lots of people get benefit from it. And also subscribe if you hadn't had time to, had a chance to subscribe, and hit the notification bell. And that'll notify you of all future topics we're having. What are the different mechanisms of atrial fibrillation? Well, we know that there are different things that contribute to atrial fibrillation. One, there could be triggers in what the areas of the heart called the pulmonary veins. Veins are blood vessels that send blood to the heart. And so the pulmonary veins are the blood vessels that send blood from the lungs to the left side of the heart. This is oxygenated blood. And inside those veins, where they enter into the left atrium, there's certain electrical tissue that has the ability to initiate electrical signals. And sometimes they can trigger electrical signals in an irritable fashion. And just think of, so you have a lot of these irritable electrical triggers in the veins that's sending signals in the left atrium. And then all of a sudden the signals get mixed up and you go into atrial fibrillation. So you get a lot of these rapid irritable signals, and we call them ectopic foci. That's a medical term. But as you can see here, this is a pulmonary vein. This is a pulmonary vein. We're looking from the back of it. So you see here the right superior, right inferior, left superior, left inferior pulmonary veins. And you see here, these are foci that can trigger signals. Over time, you can start to have what's called electrical remodeling and fibrosis. That's just a medical term for scarring. And so you start to get some scarring in the atrial tissue itself. And the more you get this, you get more remodeling. So just think of it, you get this electrical firing, the atrium starts to quiver a little bit more. And as it does this, it's associated with increased fibrosis or scarring. Now, one thing I'll say is this. We know that you have the signals and you have increased firing. And years ago, when I was performing these ablation procedures, we would go in and do pulmonary vein isolation, and they still do them now. I don't do these procedures now. I have other colleagues do them for me, but I remember going in and isolating these pulmonary veins, and people had in this area here, the early foci, and they would go without atrial fibrillation. But then over time, they would develop more atrial fibrillation. And I think what was happening, they were developing more scarring. And so the scarring and progression happens, I think, independent of the electrical triggers sending signals to the left atrium. There's a scarring, which I think is due to fibrosis and chronic inflammation that happens in other parts of the heart and other parts of the body. So you have paroxysmal atrial fibrillation, which means it starts and stops spontaneously, becomes more persistent, means it lasts longer, and then it becomes long-standing or chronic, where it's there most of the time or all of the time. Because that's the natural progression of atrial fibrillation. We try to get it treated early and stabilized early, and we'll talk about some of those treatment methods in a few minutes. So strategies to diagnose it. Typically, if you have an EKG, and here's an image showing an EKG, and many of you are not EKG experts, but you have atrial fibrillation where there's rate control. This is atrial fibrillation. There's no rate control. These spikes here are closer together here than they are here. You don't see a definite P wave. So here it was normal rhythm. See this little bump here before every spike, bump before every spike. That's a P wave. You look here, you see these little undulations here. We would call this coarse atrial fibrillation. They almost look like flutter, but it's called coarse atrial fibrillation. And maybe it's kind of a multifocal atrial attack, but again, atrial fibrillation of some sort. with rate control. So you go from atrial fibrillation without rate control to atrial fibrillation with rate control. Then if you cardiovert them, then they go into sinus rhythm, and we have rate control. This diagram here shows an electrical map. Now, this is beyond the scope of this discussion, but what I'll briefly say, again, right superior pulmonary vein, right inferior pulmonary vein, left superior pulmonary vein, left inferior pulmonary vein. So we're looking at the heart from the back. So just like imagine go stand behind someone and you had, some visual ability to look through their chest wall and into the heart, you would see the left atrium in the back, and you would see these pulmonary veins coming out from the left atrium. And so you can get a catheter and you can isolate these pulmonary veins at the origin. These two sort of coalesce into one opening into the left atrium, so they actually burned around these two together. And so they essentially isolate the electrical signals that can come from the pulmonary veins into the left atrium to keep it from triggering atrial fibrillation. So considerations of management, as I said, we want to control the rate, because if the heart rate is uncontrolled and too fast all the time, it can lead to heart failure. We typically do this with medications, have beta blockers, have rapamycin. These are non-dihydropyridine calcium channel blocks. Digoxin, I don't use digoxin very much, but sometimes it can be helpful. And in the old days, when I was in my electrophysiology training, we used to do these AV junction ablations. And at that time, we weren't doing AV pulmonary vein isolations, and we had patients who were very hard to control their rate. So we would go and disconnect the upper and lower chamber. We wouldn't totally disconnect it, but we would create a high-grade conduction slowing from the upper to the lower chamber. So that would put them in a bradycardia all the time, and they would put a pacemaker in to allow them to increase the heart rate. You want to prevent stroke, so you're going to give them quote-unquote blood thinners. We call them anticoagulants. These are medications that decrease the risk of clot forming in the left atrial appendage. And again, you want to control the risk factors. Now, we're going to talk a lot about this because I think this is where the critical factor in terms of the management lies, and things like hypertension, hyperlipidemia, obesity, diabetes, sleep apnea, alcohol use, etc. And then long-term strategies to try to maintain, at the very least, rate control with anticoagulation, or if better, you can get them in sinus rhythm and keep them in sinus rhythm. Sometimes it can be tricky knowing that you're maintaining sinus rhythm. So I think that's something that's important. So they go on here further to talk about treatment, and it outlines what I said: rate control, stroke prevention, and rhythm control. Rhythm control has been, as it was not too successful with antiarrhythmic drugs. Amiodarone is probably the best. Other antiarrhythmic drugs tend to wear out after about a year. At least about 50% effective after about a year, and then after that, even more so. So you really want to try to, maybe if the patient can tolerate amiodarone, you can use it. Most of my patients with atrial fibrillation, they come in and they have some kind of structural heart disease, congestive heart failure, or coronary disease. And so we typically, if we're using something, we'll use amiodarone, and we'll wean the dose because it has lots of side effects. And we'll talk a little bit about that, not too much. So what about stroke risk? I think that's an important concept, and that's here in this slide, or this figure, where if you have 1 point on the CHA2DS2-VASc score, so with the CHA2DS2-VASc score, basically, coronary heart disease, atherosclerosis, diabetes, sex, gender, vascular, that's the scoring system. So what do we get it from? Congestive heart failure. If you have congestive heart failure, you get 1 point. If you have hypertension, you get 1 point. If you're age 75 or older, you get 2 points. Diabetes, 1 point. Stroke, TE, a previous blood clot, you get 2 points. In vascular disease, age 65 to 70, 1 point. Female gender, 1 point. So you can get your point system based on these. So you have multiple ones of these. You can see how you can get to CHA2DS2-VASc score of greater than 2. 1, you definitely don't. You consider anticoagulation, you don't do it. 2, I may, depending on how someone got to 2, I may consider anticoagulation or may give them a chance off, and I'll share that with you regarding how I managed a patient recently. But once you get the 3, 4, 5 CHA2DS2-VASc score, you're pretty much going to anticoagulate these patients or give them a blood thinner. Maintenance sinus rhythm. I think our strategy is simply this. We have patients come in, we put them on a natural plant-based diet, we optimize their biochemistry and physiology, and we monitor them. We see a very significant conversion rate, especially if we've treated with cardioversion, some medications. We get them in sinus rhythm. We let the heart atrial remodel, and we'll wean, say, like amiodarone, wean that dose fairly aggressively over, say, 6 months to a year, and then see how they do. And we monitor them very carefully. If they're in sinus rhythm just about the whole time, then we remove the antiarrhythmic medication. So we try to maintain sinus rhythm. Catheter ablation is a strategy we also use to help, but again, we don't use that in isolation. We use that in the context of a natural diet, healthy lifestyle, to try to decrease inflammation, decrease blood pressure, decrease the weight. All of these things will have a favorable impact on not only improving cardiac function and helping them maintain sinus rhythm, but it also helps them reduce their risk of stroke. And I think if patients are aggressive enough, they can eliminate the risk for stroke. So the critical factors and a number of things discussed here. Let me see if I can rotate this view here. So this goes over different medications you can use. I'm not going to belabor this, but I want to show this on the screen. Drug therapy, beta blockers, non-dihydropyridine calcium channel blockers. These drugs here are for rate control. They tend not to be effective in converting someone to atrial fibrillation to a normal rhythm. The antiarrhythmic drugs, however, have been shown to convert patients to sinus rhythm or to a normal rhythm, but it doesn't last long. I mean, typically most of these drugs, after about a year, the efficacy is about less than 50%. And becomes a coin toss. Amiodarone, however, is a little bit better than the rest. It has a lot of side effects, a long half-life. I tend to use amiodarone more often than the others because, this works better in people, or perhaps best in people with known structural heart disease. But I try to wean the dose as low as I can while I work with them on their lifestyle modification practices. And so let me rotate this back. So in conclusion, you want to get, if you're diagnosed with atrial fibrillation, you want to, work hard to get your health under control. I recommend a plant-based diet, exercise, make sure you get proper sleep. If you have sleep apnea, get that addressed. Do the types of things that you have control over to improve your body's overall biochemistry and physiology to reduce your risk of having chronic atrial fibrillation, also reduce your risk of stroke. And what they recommended for this patient described in the vignette, they recommend that they would, get serum electrolytes, blood tests, troponin levels, identify and treat reversible risk factors. They didn't go into any details about how they would do that. Start on anticoagulant therapy, and then they perform a cardioversion to get her out of atrial fibrillation after about 4 weeks of anticoagulation. And if it recurred, then they'd make decisions regarding further therapy would be guided based on the symptoms of the like. Sometimes you go to atrial fibrillation ablation on a number of different ablation procedures that we've recommended. The catheter ablation procedure is the most common. There's the Wolf procedure, and a colleague of mine, Dr. Wolf, a surgeon who can go in and isolate the pulmonary veins from outside of the heart, and also clip the left atrial appendage, so that gets rid of your risk of stroke and the like. So let me just share with you how I would manage this patient and give you my basic nuggets on atrial fibrillation. It's a common disease, and it's one that we should be mindful of, but I want to share with you my thoughts But before I do that, we're going to go to break for a brief period of time. But before we go to break, I want you to, again, hit the thumbs up button, show us a like, subscribe if you hadn't had time to do so, hit the notification button, and also share this valuable video with friends or colleagues. So we'll be right back. Okay, we are back. So thanks for joining us and thanks for your attention. So real quick, what is my take on atrial fibrillation? As we discussed earlier, atrial fibrillation is a common dysrhythmia, one of the most common or the most common arrhythmia we deal with in cardiovascular disease in the adult population. And the main issues of atrial fibrillation are, as I see it, twofold. One is poor heart rate control, to the point where the heart gets weakened over time and you go into congestive heart failure, which is pretty bad. And two is risk of stroke. And so typically we're working to, at the very least, affect those two contributing factors. But I'll put those aside, but I'm going to step back and think about think out loud with you about atrial fibrillation. And so what is atrial fibrillation? Yes, it's a heart rhythm abnormality. But I like to think of it as an overall manifestation of an underlying chemical and biochemical and physiological imbalance. We've talked earlier in the talk I did on inflammation of the heart, and I talked about how inflammation and increased inflammation, increased oxidative stress contribute to electrical abnormalities. And some of these electrical abnormalities resulted in abnormal calcium influx inside the myocardial cells or the heart cells. This can lead to ventricular arrhythmias or atrial arrhythmias, in particular atrial fibrillation. So we know mechanistically biochemical and physiological imbalance contributes to atrial fibrillation. So I want us to kind of take that understanding and apply it to a greater understanding of saying, well, atrial fibrillation is not just some condition of the heart, but it's an outward manifestation of the heart of an underlying biochemical and physiological imbalance. And so we need to address that biochemical and physiological imbalance. And in fact, you support that argument by showing that atrial fibrillation is associated with other things that are related to biochemical and physiological imbalance, such as hypertension and diabetes and obesity and the like. So all these things are related to inflammation and increased oxidative stress. So if you're dealing with that, instead of just dealing with atrial fibrillation by itself, perhaps we can deal with the underlying cause that's contributing to all of these conditions. So that's why I like to aggressively affect patients' nutritional status, get them to the point where they're able to exercise or sleeping better, and their overall biochemistry and physiology is in line, and then the body starts to correct itself. So I'm getting some questions. Let's see, what questions am I getting before I get to some of my concluding remarks? Even metoprolol, they ask about metoprolol is a beta blocker and it helps with rate control. It has not been shown to be effective in converting somebody from atrial fibrillation to sinus rhythm compared to placebo. And Jackie's reminding me, Stump to Chump tomorrow night at 7 p.m. So everybody send your questions in for Stump to Chump. I guess you can ask questions about atrial fibrillation as well. And what does food do to help? Well, food, if the right kind of food, it decreases inflammation, decreases oxidative stress, and remove the wrong food, the inflammatory processes start to correct or subside. And conditions such as atrial fibrillation become easier to control if they don't just convert on their own. So this takes you to a situation where I was dealing with a patient just last week, a 75-year-old man who presented to us a number of years ago, had atrial fibrillation, congestive heart failure, poor rate control, and we admitted him to the hospital on more than one occasion. The more recent time we admitted him, he underwent pulmonary vein ablation procedure. We saw him on amiodarone. He was on blood thinners, and we put him on a diet. We put him on a several detox regimen, and he followed this plant-based regimen for a long time. We did extensive cardiac monitoring. We also weaned the amiodarone while we monitored the heart. We take him off amiodarone. He's off amiodarone for more than a year. Still consistent sinus rhythm, not seeing any atrial fibrillation. And so he was on the blood thinner. He was on the Pixaban, 5 milligrams twice a day. And so he was being anticoagulated. And so he said, well, can I get off the anticoagulant? So looking at his situation, he's 75 years old. So he has a CHA2DS2-VASc score of 2. But the heart failure was reversed because the heart pumping function went up to 50%. The hypertension was reversed. He has no diabetes, no obesity. He doesn't have sleep apnea. He's, eating a very healthy plant-based diet, 100% time, exercising, working out, and feeling great. And so I made the judgment call to say, okay, let's see how you do for 6 months. We'll just go on an aspirin, even though this article says aspirin doesn't show any benefit. There was a study years ago in one of the warfarin trials that showed aspirin at 325 milligrams showing an interim benefit. Wasn't as good as warfarin, but it was better than placebo in that one trial. So given that information, but more importantly, how well he did, he had an atrial fibrillation ablation. He's done very well in his lifestyle modification. We've seen no traces of atrial fibrillation in the last, I think it's been maybe 4 years that we've been monitoring. So we said, okay, come off the anticoagulant and let's see how you do. So far he's done quite well. And I think it's the best course of action for him. He said, it's my desire to come off medications totally. And we say, okay, let's work with you and we'll make that happen. So I thought it's a good decision to make in him, and, time will tell, of course. And we follow him as well as all of our other patients very closely. So that's the scoop on atrial fibrillation. I hope that was very helpful for you tonight, this afternoon, I should say. And we look forward to seeing you next week. And until then, keep it fresh, natural, and live.